So in this lecture, we get to start another body system, the cardiovascular system. Cardiovascular disease kills more people than anything else, so it's kind of a big deal for pathology, kind of a big deal for the medical profession. We're going to start off with blood vessels, blood vessel disease, and some damage to heart muscle, kind of cardiomyopathy means heart muscle disease. We'll look at some of those. And then we'll have a lecture specifically on ischemic heart disease, which means heart attacks, and one on heart failure, which is anything that decreases heart function over time and can cause you to die from that. So those are the two main ways you die. These are a couple of the ways that the disease forms in the first place. First of all, let's look at some vein and arterial diseases. Diseases of the veins, there are a couple of problems. Veins are very low pressure. The blood moves pretty languidly, slowly, and it can hang out for a while. It should never stop. When blood stops, it clots. And so even if it's moving slowly, it's kind of like being in a ski lift line where, you know, you ski really fast and you go up the line and you stand in the line for a while. You keep shuffling along, but you get on the chair and you go up and you ski back down. So in the veins, it's constantly moving back toward the heart. Exercise moves it back faster, but you know, it's a slower moving. So you have low pressure, you have slow movement, you have one-way valves that keep the blood moving back toward the heart instead of letting it go the wrong way. So anytime you manage to smash a vein, it'll move the blood in the right direction. So that's all good, but if the veins become weak or the valves become insufficient, the blood can start to pool. It can cause problems. One of these venous problems that affects mostly older people whose vascular walls have become a little bit weakened and the muscles around those walls have become weaker. Varicose veins, very common in older people, common in people that are on their feet a lot, common in pregnant women who produce a lot of extra pressure during their pregnancies, and it prevents the blood from coming out of their legs fast enough and stretches out the blood vessels. So a vein, the blood pools there. It doesn't move very fast. They can be distended, stick out, and look bad. And if they get bad enough, they hurt a lot. You can have them fixed. They can be surgically fixed. A lot of times you just block off the vein because you have other veins. They're not very high pressure. The blood may find some other way to get there. Sometimes by trauma. Age, females. If your parents had them, you're likely to have them. Obesity and pregnancy. Deep vein thrombosis. If you have blockages, blood clots in the deep veins, that's a bad thing. And leg injury or surgery that causes scarring that blocks some of the venous return, the blood coming back to your heart. Here's a varicose vein. Very likely this one isn't terribly painful. It may not be painful at all. It hasn't gotten that huge, but they did have it surgically repaired, and now look, you can't even see where it was. Chronic venous insufficiency, which can come from just weakened veins, if they're on the surface, they become varicose. If they're deep veins, they become weak and blood sits there too long. And you don't get enough venous return. The blood hangs out in them too long. You start getting vascular damage. You start getting tissues that are not getting perfused properly. Venous stasis will block off blood flow through clotting and therefore cause ulcer damage. You can get venous stasis ulcers in diabetes because you have poor blood flow in the legs in diabetes. Deep vein thrombosis means not the surface veins, but the ones coming up the middle of your leg get blood clots in them. A thrombus that is formed there because the blood slowed down too much, blocks off the vein, and now the blood can't get out of the leg, and the leg swells up. It becomes very painful. It becomes very serious. One of the main problems with deep vein thrombosis is those blood clots can break loose and come back and give you a heart attack or a stroke. Venous stasis, lack of movement. People get deep vein thrombosis. Older people, long airplane flights. It's really a common occurrence and well-known problem for travelers, older travelers sitting in the seat for a long time, not moving, get a deep vein thrombosis and have a stroke when they get off the plane. I actually, on my last international flight, they came on the loudspeaker and said, every once in a while, get up and just walk to the back of the plane and come back and sit down again. It was the first time I ever heard the flight attendants tell us that. Damage to the veins can cause it. Hypercoagulable states, in other words, if you are on birth control pills or you have cancer or something that causes you to clot more frequently, will make this condition more likely to happen too. Surgery. You have surgery, you have some vascular damage, usually some scarring that causes some impedance of flow. As a result, very soon after you have surgery, they get you up and have you staggering around the hospital with help so that you don't develop deep vein thrombosis. Also pneumonia from lying on your back too much. Superior vena cava syndrome. Well, this is interesting. Here we've got the vena cava. Superior vena cava is bringing blood out of the arms and the head back to the heart. Coming up from the bottom, it's the inferior vena cava. But sometimes you'll get a tumor or some other stricture that will slow down the return of blood from the upper body. This is what the guy looked like before he had it, and now the blood is all pooling in his head. His carotid or his jugular veins are going to stick out, probably going to have veins sticking out on his arms because the blood is unable to leave. It can be extremely serious. It says it's an oncologic emergency. If a person actually has a tumor that's causing it, they got to take the tumor out. It's that serious. Hypertension, high blood pressure, is a chronic problem in Western civilization. We're too heavy. We don't exercise enough. We eat too much salt. You name it. Our blood pressure has gotten higher and higher over the decades. Primary hypertension means that you have hypertension even if you're not sick from anything else. Nothing else is specifically causing it. Your homeostatic imbalance is just such that it leaves your blood pressure too high. And so a lot of it's hereditary. Some people have hypertension even if they're skinny, if everything else is okay. But genetic and environmental factors combine. This is a multifactorial illness in that how much you exercise, what you do, what you eat, how much you weigh, all of those will combine with your predisposition. How sensitive you are to salt is a big deal. Some people can eat a lot of salt and it doesn't change their blood pressure. Others, their kidneys are sensitive to salt and they will start retaining more water when you have more sodium in your blood. And as a result, every time you eat salt, your blood pressure goes up. Natriuretic peptide abnormalities, if you're unable to produce the ANP that causes a release of some of your fluids. Obesity, insulin resistance causing vascular changes that don't allow relaxation as much. Secondary hypertension means it's caused by some other disease. You have another disease that makes your blood pressure go up. Renal artery stenosis. I mean, if you have a blockage in a renal artery, you can't get enough blood into your kidneys to make enough pee, and you'll start retaining water and your blood pressure goes up. So that's a secondary problem that could be repaired. Primary, genetics, environment. Inflammation, which results in vascular problems, water retention, insulin resistance. Here we have dysfunction of the sympathetic nervous system. Sympathetics cause vasoconstriction and your blood pressure to go up. The renin-angiotensin-aldosterone system. You remember how that causes, if you have low blood pressure, you make renin, you make angiotensin, you make angiotensin 2, you produce aldosterone, you retain water at the kidneys. That is your main blood pressure increasing system. If it is overactive, your blood pressure goes up. So if you're vasoconstricting, you're squeezing the blood. If you increase your blood volume, you have more blood. Overall, your blood pressure goes up. High blood pressure is very damaging to your heart and your blood vessels. Complicated hypertension means it's starting to do damage. You can have high blood pressure and nothing's gone wrong yet. If you control it, you can be perfectly healthy. Or if it's gone on long enough, you have vascular wall damage, you have heart damage, you can have valve damage, hyperplasia of the heart muscle that's trying to pump so hard, hyperplasia of the blood vessels that are trying to control this extra pressure. And if it happens in the retina, it can make you go blind. It's one of the retinopathies with diabetes. Diabetes is often associated, well, it's insulin resistance, it's high glucose, glycosylated hemoglobin, not a good thing, and development of thickening of walls of blood vessels. Retinopathy can make you go blind if you have diabetes. It can cause heart attacks and it can cause strokes. It can cause, the inflammation can result in thrombus, thrombi and aneurysms. Remember, inflammation activates all parts of the immune system, including the clotting mechanism. They all communicate. Chronic inflammation, increased blood clotting, higher pressure, aneurysms that can pop. Malignant hypertension means it's getting higher. You're in the hospital, the blood pressure goes up. You check it again, it's gone up, it's gone up, it's gone up. It can be lethal. It can damage and destroy your organs. Hypotension means you don't have enough blood pressure. Orthostatic hypotension is when you stand up and all your blood falls to your feet and you pass out and fall over. Happens to old people all the time. Their walls of their blood vessels are kind of weak. The muscles aren't as strong. The valves aren't as good. And so they stand up and too fast and they get dizzy and they fall down and break their hip. Syncope. That's fainting. The pressure response, you're not only supposed to have a constriction of blood vessels when you stand up, but your heart and aortic arch are sending back signals that should cause an increase in heart rate when you stand up to help maintain some blood pressure. It may not. Of course, another reason to have hypotension is if you bleed all your blood out on the floor. But we'll talk about hypovolemic shock and stuff later. An aneurysm, of course. We can have aneurysms in any blood vessel. You can have them in your brain, resulting in a hemorrhagic stroke. Here's an aneurysm in a blood vessel in the person's leg after they had knee replacement surgery. Kind of cool looking artificial knee joint there. The aorta is very susceptible, really high pressure, and it's got a big cross-sectional area which produces greater lateral pressures. If there's anything that causes a weakening of the aorta and it bulges a little bit, the pressure gets worse, it bulges more, bulges more, bulges more. Marfan syndrome, which is a genetic problem with connective tissue development, predisposes people to aortic aneurysms. One of our best U.S. Olympic volleyball players in history died on a court in Japan. She was tall and skinny. They should have maybe suspected she had Marfan's. Turns out she did, but by the time they found out, she was dead. Her aorta popped while she was playing volleyball on the court, and she just collapsed and died. Aortic dissection means that the tunica on the outside has split. If it's just bulging, it's just bulging. If it's dissecting, it's getting ready to pop, and rupture means it actually blew up. Here we have our aneurysms again. It's not showing a berry aneurysm. Remember that sticking out on the side. A fusiform, saccular, I guess this would be a berry if it became big enough. Here's the fusiform. It means all the way around or circumferential. Dissecting, now you're starting to actually break the connective tissue. And here, this is a false aneurysm. It was a broken blood vessel that formed a clot, and now if you look at it under some, like under a ultrasound or something, you'll see a bulge on the side of it, and you'll say, oh, this guy has an aneurysm. This may heal up just fine. Here's an abdominal aortic aneurysm. You think of the aorta as being the aortic arch, right? But the aortic arch goes straight down the middle of the body all the way to here, and the main blood vessels come off the side of it. And it's the aortic, thoracic and aortic aneurysm that normally have the, aorta that normally develop the aneurysms. So here's one. It's not in the aortic arch. It's somewhere a little farther down. Looks like this guy didn't actually do too well. His heart, his aorta, and kidneys are all lying on a table somewhere. It's usually a bad sign. We can form blood clots, especially if you have inflammation, which results in increases in clotting mechanisms. We can have increased clotting factors, too much von Willebrand factor, too much factor this and that and the other, your clotting factors. You can have stasis of blood. It stops moving, forms a blood clot. Deep vein thrombosis usually is that way. Also, what am I trying to say? Fibrillation, Afib, atrial fibrillation. Sorry about that. Afib, your upper part of your heart is, instead of beating and pushing the blood down into the ventricles, it's just quivering. The blood sits there for too long and starts forming little blood clots. Okay, well, anybody with AFib normally is taking at least aspirin, if not some kind of other blood thinner, clot resistant medicines. Heparin. Risk factors include inflammation, injury, obstruction of flow causing stasis. An embolism, as we'll see on the next slide, is a thrombus that is going somewhere else. A thrombus affects the area where it was formed. An embolism is anything that broke loose and went somewhere else and blocked a blood vessel. So a thromboembolus is a blood clot that has broken loose and gone somewhere else to cause pulmonary embolism, stroke, heart attack, something. Thrombophlebitis is an inflammation of blood vessels in the lower legs. Famous case of thrombophlebitis, Richard Nixon, after he was impeached and forced out of office as president. He never went to court. When he was no longer president, he could have been brought to court, but he developed thrombophlebitis and was too sick to go to court. Arterial thrombi, if you develop a thrombus in an artery, remember arteries get smaller and smaller as they get toward the capillary beds. So you're almost sure to have a thrombus that affects that area or an embolism that is pretty close because it's going into smaller blood vessels. Venous thrombi, because veins coming back toward the heart are joining bigger and bigger and bigger veins, they're more likely to break loose and become an embolism that travels somewhere pretty far away. Embolism, chunk of stuff that blocks a blood vessel somewhere other than where it was created. So a dislodged thrombus that floats around for a while, maybe goes all the way through the heart, goes up the pulmonary artery and blocks a big blood vessel in the lung. Can be an air bubble, amniotic fluid, a fat glob that breaks loose somewhere. It can be a blob of bacteria. Cancer cells that are in the bloodstream can actually clump together and form a little bit of a little embolus. Another thing that can block blood flow is vasoconstriction, abnormal amounts of vasoconstriction. Raynaud phenomenon and Raynaud disease are two, they look the same. The disease is a condition you have that's not caused by something else that causes your hands to be blue and cold all the time. You constantly have vasoconstriction going out to the extremities, sometimes the feet, most often the hands. Your hands are freezing all the time, and I've known a person or two who's had this. It's pretty uncomfortable, but that is like primary. The phenomenon is if that same thing happens, but it's caused by something else. Vascular disease that blocks the flow to your hands. Smoking causes vascular disease and vasoconstriction sometimes. Pulmonary hypertension, which doesn't allow the blood to leave the lungs properly or the heart properly. And if you're really cold, some people respond to cold very dramatically. It's like sticking your hands in ice water. They become whitish blue and very little blood flow through them. Speaking a bit about the main problem with blood vessels that kill so many people, again, we're going to have an ischemic heart disease lecture coming up next. We're going to start off with the most general version of this blocking of blood vessels, referred to as arteriosclerosis. Your arteries are getting hard. Hardening of the arteries. It happens to everybody when they get old. Their arteries get harder. They don't stretch as well, so it doesn't control your blood pressure as well. They don't allow blood flow quite as well as they did when you were young. And it's caused by a thickening in the wall, usually damage to the endothelium over time, causes a migration of cells, immune cells, into the area right below the endothelium. You thicken the smooth muscle layer around there because that's one of your main mechanisms for patching. The tunica gets hard, or the adventitia gets hard around the outside, stiffens with age like everything else does, and you get a smaller hole, a thicker wall, and less blood flow. It happens throughout the body. All of our blood vessels incur some arteriosclerosis. This is likely to result in peripheral artery disease, PAD. So if your peripheral arteries, now they can be damaged by something else. They can be attacked by an autoimmune disease. Or you can have plain old hardening of the arteries that doesn't allow enough blood to get to your extremities. Diabetes causes peripheral artery disease. Very common. You wind up having to have your feet amputated. One of the first indications of peripheral artery disease is what's called intermittent claudication. It means intermittent pain. So while I'm standing around, there's enough blood getting to my muscles, but I start exercising a little bit, and my muscles are demanding more blood, and they can't get it because the blood vessels aren't good enough, and you get kind of cramping pain in your legs. Intermittent claudication is a good indication that you're in the process of developing peripheral artery disease. Thromboangiitis obliterans, this means blood clot causing inflammation of blood vessels and obliterating their ability to carry blood. It's a remarkable name. Interestingly, mostly in young men who smoke, it's like medium-sized arteries become inflamed and blocked by tiny blood clots. They're not caused by the arteriosclerosis, atherosclerosis process that you're used to. It's simply an inflammation of these blood vessels that causes additional clotting and lesions that block them off. And it can wind up in having your feet cut off. So it's a lot like a diabetic angiitis, but it's caused by cigarette smoking if you happen to be susceptible to that. Atherosclerosis is not exactly the same as arterial sclerosis. This is a general hardening of arteries. It can be caused by atherosclerosis or by just a fibrosis of the blood vessels over the lifetime. Atherosclerosis is specifically caused by inflammation of blood vessels causing arrival of monocytes penetrating into the area, dying and leaving cholesterol clumps behind, building up a plaque, and blocking your blood vessels. It happens most commonly in the coronary arteries and causes heart attacks, and it happens in carotid arteries, atherosclerosis. If somebody has those plaques built up so that they're not getting enough blood to their brain, they go in and do a roto-rooter and scrape it out of there and try to open it up so they get more blood going through. The main development of coronary artery disease is through atherosclerosis. And this shows the early stage, little bit of penetration of macrophages and building up of lipids, not inside the blood vessel, but behind the endothelium. Gets bigger and bigger. You get a proliferation of smooth muscle cells trying to cover it up. Here they have kind of covered it up with smooth muscle cells and some collagen. But if the problem isn't solved, it continues, it continues, it continues. It keeps swelling and swelling until it pops and forms a thrombus, which kills you. That's what gives you your heart attack. Here's the progression. We'll talk about this a few times. Inflammation, inflammation, inflammation. That's what starts it. It's not just eating too much fat. That helps because too much fat gives you too much cholesterol. Too much cholesterol causes oxidation of cholesterol. Oxidized cholesterol causes inflammation. Inflammation starts the process. And then you have too much cholesterol also to help form these plaques. I will say that there's less and less specific indication that cholesterol is the primary problem. There are other things that seem to actually be more indicative than high cholesterol of having the inflammation that is going to result in these blockages. However, those other factors mimic the rise in cholesterol, so at the moment cholesterol is still considered one of the primary risk factors and a great diagnostic tool, even if maybe it's only there because the really bad guy is. So stay tuned, there'll be more to come on that. Inflammation. The immune system shows up, that's what inflammation is, penetrate, cellular proliferation of smooth muscle trying to put a patch over the cap. The macrophages come in, they penetrate. The LDL oxidation of the substances taken across the membrane by your own immune cells. Hey, they're carrying cholesterol with them. It's a good thing to use for repairing cells. Trouble is you don't have any cells that need repairing at the moment. So when your immune cells die in there, they leave that deposit behind. Formation of the fatty streak, which is that layer of fat underneath the endothelium. The fibrous plaque that develops over the top. Complicated plaque made up of smooth muscle cells, fibrosis, splitting, damaging, and blowing up, allowing the blood clot to go out and perhaps kill you. And if it doesn't, now you've damaged the endothelium again, more immune cells, more plaque. So if it ruptures a couple of times, it gets bigger and bigger and bigger each time until it blocks off your flow. I'm kind of getting ahead of myself because that's like ischemic heart disease, but it doesn't hurt for you to hear this a couple of times. Risk factors: high lipids or the wrong variety of lipids, too much LDL cholesterol or too little HDL cholesterol, too high triglycerides, diabetes causing vascular damage and inflammation, smoking, inflammation of blood vessel walls, and hypertension causing physical damage. Risk factors. Now this is an important one. I think I don't mention this one in the ischemic heart disease lecture. These are the risk factors that have been found individually to make you more likely to have atherosclerosis, particularly in your heart, but also your carotids, maybe some other places. Increased age. Men over 45, women over 55. Women are protected until menopause, then they start catching up. So if you're older, you're more likely to have heart disease. That would be me. Family history. Doesn't mean your family came over on the Mayflower. It means your father, your mother, your brother, your sister had documented heart disease, especially at a young age. Mine didn't. I'm okay there. Male gender. Damn, that's me too. Okay, so I've got a couple of risk factors already. Female gender after menopause. Again, it used to be only male gender, but now females after about 55, again, that moves them into a risk factor by not having the protective effects of estrogens. Nothing you can do about these. But you can do something about all the rest of them. If your cholesterol's too high, you can do something about that. You can exercise more, you can eat better, you can take lipid-lowering medications if need be. Hypertension, you can lose weight, you can take hypertension meds, you can exercise. Cigarette smoking, you can stop. Diabetes, you can lose weight, you can control it with insulin if you're insulin dependent. Obesity and sedentary lifestyle. Obesity is a risk factor. You can lose weight. Sedentary lifestyle, you can get up and start walking. Sedentary lifestyle. This is somebody who doesn't have an active job that has you on your feet all day and doesn't do any intentional exercise out of work. And an atherogenic diet. Don't eat hydrogenated oils and tons of saturated fats. Eat fruits and vegetables. You know, we know about that kind of stuff. The same kind of stuff that prevents cancer. Why? Helps reduce inflammation. Anti-inflammatory type stuff. Antioxidants. Those prevent inflammation, which can cause both cancer and heart attacks. Some other risk factors that we have not put on our original list but are coming to the fore. They may basically tell you if you're more likely to make a clot or more likely to have inflammation than the average guy. So, C-reactive protein and homocysteine. Those are two markers of high inflammation. If you have unusually high C-reactive protein or homocysteine, you have an additional risk factor for heart attacks. Some of these signaling molecules, the cytokines that indicate infections and inflammations, if those are elevated, it's an indication that you are at least responding as though you have higher inflammation than normal. And von Willebrand factor means you'll be more likely to clot. So these things would give you an increased risk of having a heart attack as well. Let's look at some of the diseases that can affect the actual heart wall. Let's look at the pericardium first. The pericardium is the sac that surrounds the heart. It's full of fluid. It allows the heart to move in there without rubbing against your lungs, causing damage to both the heart and the lungs. Gives you this nice little fluid-filled bag to do its job in. The pericardium can get inflamed. It can get diseased. It can get inflamed. It can get so inflamed it starts leaking excess fluid. It's called pericardial effusion. Acute pericarditis. You have a bacterial or viral infection or some other kind of infection of the sac around the heart. If it's bad enough, you get effusion. It starts filling the sac up with water, essentially. Cardiac tamponade fills it with blood. If you have a rupture of a blood vessel inside that pericardial sac, either on the surface of the heart or the sac itself, you can start filling it up with blood. If it fills up, effusion's slower. This can be fast. And if it fills up enough, it can only stretch so far. The pressure on the heart will prevent the heart from beating and you'll die. So on Trauma Life in the ER, they're always bringing somebody in. They're finding out his the pericardium is full of blood, and they stick something in there and blood shoots out and the guy's okay. Doesn't always work out that way, but that's where that comes from. A cardiomyopathy is a heart muscle pathological condition. So it's not the pericardium, this is the myocardium now, the heart muscle. And we can have a couple of different kinds of cardiomyopathies. Some of them can actually be an infection, but our two main cardiomyopathies are caused by, heart failure type problems, high blood pressure, a valve that won't open or close all the way and puts too much stress on the heart. And so the muscle either stretches out like mad or gets muscle bound. A dilated cardiomyopathy is something where the filling of the heart is so much greater than the emptying of the heart, it stretches out, and they call it an enlarged heart. They can become huge, weak, they can't push the blood out very well. We'll see this during our heart failure lecture, but that's a dilated cardiomyopathy. If you're fighting against, for instance, an aortic valve that won't open wide enough, and you're pushing harder than you should with every beat, you have a tendency to get an overly muscular wall. It gets so thick it fills up the chamber and there's no room in it for blood. This is a hypertrophic cardiomyopathy, and either one of them can kill you if it gets bad enough. Restrictive cardiomyopathy, the wall hasn't changed shape, it just gets stiff so it won't move very well. So one, it stretches out too big, one, it gets so thick there's no room inside, and the other, it just doesn't move well enough. So here we have normal, it beats. Dilated cardiomyopathy, it's really big, it doesn't pump very much of the blood out. A lot of the blood is left behind at the end of each beat. Hypertrophic cardiomyopathy fills up the chamber with muscle. And restrictive cardiomyopathy looks just like this one, but it won't move. Some of these myopathies are caused by valve problems. Some of them are caused by hypertension for 50 years that make your heart work so hard it just starts to give up. But some of it is because the blood can't move through a valve properly. Valvular stenosis means it won't open wide enough to let the blood go through. Aortic stenosis and mitral stenosis are the two biggest problems. Mitral stenosis won't let the blood go down into the ventricle. Aortic stenosis won't let it leave the ventricle, and the ventricle has to work extra hard. Valvular insufficiency causes regurgitation. What that means is the valve lets the blood go down into the ventricle, but then it doesn't close. So when the ventricle squeezes, it shoots back up in the atrium. Or aortic valve insufficiency. You blow it out into the aorta, but between beats it all squirts back into the heart. Not all of it, or you'd be dead, but a reasonable amount does. Aortic insufficiency lets it come back in the ventricle, not the way it was supposed to go. So stenosis doesn't let it go out. Insufficiency lets it come back in between beats. Mitral valve prolapse is a mitral valve between the atria and the ventricles that lets the blood go down into the ventricle, and it stops it from coming back. But when you beat, the valve is so weak, it bulges back up. It doesn't actually allow it. You might have insufficiency too if it's bad enough, and some of the blood would come back up. But instead of it holding firm while you pump the blood out the aorta, it's allowing part of the blood just to bulge back up toward the left atrium. So not as much is able to go out. Mitral valve prolapse is most common in tall, athletic women. Their hearts are big and strong. Because they're women, their connective tissue is softer and looser than it is in guys. That's why they can do splits and stuff better than we can. And therefore, their heart beats hard. And their chordae tendineae and things that are trying to hold their valves in place are weaker, and they get mitral valve prolapse. In many, it's not a problem. They can live with it. But it's not a perfect scenario. It leads to a little bit of less efficiency in the heart pumping mechanism. Valvular dysfunction, normal open, close. Stenosed valve, this is open, but it didn't open very far. Regurgitant valve closed, but it didn't close all the way. And it allows blood either not to squirt through very well or to squirt back when it's not supposed to. These usually result in heart murmurs because that squirting blood makes a noise. And you'll hear the heart murmur during some part of the beat. Rheumatic fever can cause heart disease, a heart infection. Rheumatic fever, usually in young people, usually strep throat. In older people, it's often caused by gum disease. You have infections of the gums that are there all the time, and these bacteria can leave the gums. They're blood vessels all around there. That's why your gums are so red. And they leave the gums, and they wind up migrating to your heart and living there and causing a cardiomyopathy through disease. They can invade the valves. They can invade the heart itself. And so rheumatic fever, if it's not treated properly, causes rheumatic heart disease. So you get the rheumatic fever first, and then later some of the bacteria that weren't completely eradicated wind up living in the heart and damaging your heart. Bacteria, viruses, fungi, parasites, these can all infect the heart. It's bacterial if it's rheumatic fever, because that's strep. But any of these things can invade, heartworms. Dogs get them. People usually don't, but it doesn't mean you can't have parasitic infections of the heart muscle or of the valves. You can damage the heart wall, inside, the outside, and the proliferation, the growing of these organisms in a place that somehow seems to be good for them. A lot of times they won't go and stick on the wall of your kidney, but they seem to like to attach to the heart, and especially the heart valves. Infective, so you can have a non-infective endocarditis with a variety of things that cause inflammation. Inflammation, a sterile endocarditis, means that you have, high C-reactive protein, you're smoking, you have some other congenital heart problem, it causes inflammation in there, and you have damage to the muscle from that. Or it can come in through here as a bacterial or viral or fungal infection and start building up on the heart wall or the valves. Here are vegetations on the inside of the heart. If these are on a valve, the valve can't close. It's one of the main reasons for valvular insufficiency is it gets rough on the edge because it's got bacterial growth or fungal growth or something on the heart valve itself, so it can't close all the way. And HIV, because it causes direct damage to nerves and stuff, and because it allows opportunistic bacteria, viruses, and funguses to just run rampant, causes all kinds of blood vessel and heart disease as well. It causes encephalopathies in the brain, it causes neuropathies, it causes inflammations of the muscle of the heart, the inner layer, the sac around it, pericarditis, because all sorts of opportunistic organisms come in, or just inflammation in general causing these. Cardiomyopathies, damage to the heart muscle. Pericardial effusion, filling up of the sac. And if you damage the blood vessels through these inflammatory mechanisms, you're going to have a loss of blood flow to the heart. And this is where we'll pick up in the next lecture with ischemic heart disease. It's the way most people get heart disease and die of heart attacks. Ischemia or ischemia means you're not getting enough blood flow to a muscle. It's not dead yet. It's not a heart attack. Ischemia just means a low oxygen flow to that muscle. Usually you don't notice it until you're exercising, because at rest, even a tiny amount of blood's enough. But you start exercising, the heart needs more, it can't get it, and you start getting ischemia. Now, this means, usually it means it hurts. Angina pectoris, or angina pectoris, means under your pectoral area you have pain, and that's chest pain that you get when you're having an ischemic attack. It doesn't necessarily mean you're having a heart attack. You could be having an ischemic attack. That's a great warning that you better go get something done. Stable angina, chest pain usually during physical activity. It happens about the same exercise level each time, and when you back off it kind of goes away. Unstable angina means it comes and goes whether you're exercising or not. That's worse. Prinzmetal's angina is the blood vessels aren't blocked by a plaque, they are constricting abnormally due to an over response to your own sympathetic nerves under severe stress, fight or flight, and you get chest pain. People who are stressed out are more likely to have heart attacks, partly because they may be partly blocked, and if they squeeze, it blocks the rest of the way. But Prinzmetal's by itself is just a vasospasm. And when it goes away, if you have a test, it doesn't look like there's anything wrong. There's no blockage there. Silent ischemia means there's no pain. A certain percentage of ischemic heart conditions are painless. That's actually more dangerous. You don't know that there's a problem. Myocardial ischemia, coronary vasoconstriction, or a partial blockage, and the area downstream from it doesn't get enough oxygen and it starts to cramp up. The electrocardiogram shows the ST segment dropping. ST segment depression is ischemia. Usually accompanied by chest pain, and it could tell you that you're going to have a heart attack before long, especially if you don't do something about it. You can take nitroglycerin tablets, put them under your tongue. It's a vasodilator, and it will relax all of your blood vessels, including your coronary arteries, and sometimes stop the pain. And your acute coronary syndromes are ischemias, anginas, heart attacks. Something that happens right now. My arm hurts, my jaw hurts, my chest hurts. I'm having a something or other. I'm having an ischemic attack. I'm having a heart attack. Transient ischemia might come on during exercise and go away. I mean, you don't want this, but it's better than anything else. Unstable angina just comes on, you're sitting watching TV and suddenly it hurts. That's worse. Sustained ischemia, you get this pain, angina, and it doesn't go away. You better get to the doctor because ischemic heart muscle doesn't work very well. It doesn't get enough oxygen. It won't beat very well. It can wind up causing further heart problems like a heart attack or a variety of other problems. Or a myocardial infarction, an MI, is a heart attack. A heart attack. And they come kind of in two different types. ST segment elevation is a heart attack. We'll see that next time too. Here we have ST segment depression. That's ischemia. If the ST segment goes up instead, you're having a heart attack. ST segment elevation ischemia, heart attack. What it really means is the heart attack is going all the way through the heart wall so that it shows up on those electrodes that are looking at it. So that's a STEMI. In-STEMI means non-ST segment elevation heart attack. It means the heart attack didn't penetrate the entire wall, stayed on the inside where it starts usually. It's not showing up out here, and so you don't get your EKG indication of a heart attack. And in-STEMI is a little harder to diagnose because you don't have the ST segment elevation from your EKG. STEMI, more typical, you do get the ST segment change, and you can tell that the person's having a heart attack. Myocardial inflammation, damage, and finally death to heart muscle. So what happens if your heart doesn't work? Well, there are a couple of things that can cause you to die of lack of blood movement. Certainly if your heart stops or if it fibrillates so you can't pump enough. You can have a cardiogenic shock because your heart isn't working, heart-caused shock. There are a variety of other ways that you cannot have enough blood moving. How about if you bleed all your blood out on the floor because you cut your foot off? That's a non-cardiogenic shock, and you still wouldn't have enough blood. Shock happens when you don't have enough blood pressure to keep you alive. So, inadequate perfusion of tissues, not enough blood movement. It can not move, it cannot have enough pressure, you can have not enough blood. Any of those things will mean that your tissues aren't getting the oxygen they need. And it's one of these circle the drain kind of things. If your cardiac output drops and your blood pressure drops, you don't have enough blood coming back to the heart to even nourish the heart, so it'll work even worse. So your cardiac output will drop, and your blood pressure drops, and your cardiac output drops. Meanwhile, your other organs, like your kidneys that are designed to have decent blood flow, now don't. They start to fail. That causes further shock. And so the more shock you have, the more effect you have, and the more effect you have, the more shock you have, until you die from it, unless you do something about it. Low cardiac output causes shock. Shock causes more cardiac output. And irreversible shock, even with blood pressure, is the ultimate result. So somebody bleeds out enough, you get them back, and you fill them back full of blood with a blood transfusion, and they die anyway, because there was so much damage to the blood vessel walls and the other organs, it just can't recover. So you have a non-progressive type of shock. If you bleed out 2 pints, you're in some sort of shock. If your heart goes into a momentary arrhythmia, you can go into momentary shock, but you can compensate, you can come back. Your blood vessels can constrict sympathetically. You can start retaining water because low blood pressure will cause the renin-angiotensin-aldosterone system to kick in. A certain amount of cardiovascular, deficiency can be compensated in some cases and keep you stable, at least for a while. Progressive means that it's gotten bad enough that you can't get back to normal, so this is causing this. But for a while, if you add blood, or if you fix what's wrong with the heart or something, you can come back. Irreversible, so much damage has been done that no amount of replacement of fluids can make you healthy again. So here, we're just looking at blood removal here, but the same thing can happen if blood vessels dilate too much or something, your heart slows down. But here, cardiac output is dropping way down, but for a while you can still maintain your blood pressure through other mechanisms to keep you alive. After a while, though, the blood pressure starts to drop too. After a while, it becomes irreversible in that an increase in blood volume would not actually cause you to move back into a healthy scenario. Types of shock. Cardiogenic shocks are shock that's caused by the heart. So heart failure or heart attack. There. Heart failure, where the heart just beats slower and slower, worser and worser, dilated cardiomyopathies, huge heart that's barely beating. Or a heart attack where it stops altogether, perhaps. Everything else is not cardiogenic. All of these other things are caused by something other than the heart. Hypovolemic, not enough blood. You just bled out on the ground. Neurogenic. The nerves overstimulate the vasodilatory response. It happens if you're in a car accident and your nervous system is overstimulated in a monster, attempt to, solve the problem. And it causes a dilation. It can be overstimulation by nerves or understimulation. Overstimulated by parasympathetics, like, if you see a terrible thing and you pass out on the ground because you've had a parasympathetic stimulation. A withdrawal of sympathetic that allows all your blood vessels to relax. In any case, your blood pressure drops down and you die. If somebody's in shock, you're supposed to lay them down and elevate their feet. Keep some blood up in their head. Try to keep them alive until the shock can be dealt with. Anaphylactic shock, a major allergic reaction through anaphylaxis, huge histamine release. Substance of anaphylaxis release, bee sting or something. What actually kills the person is a system-wide inflammatory response, causes all the blood vessels to dilate at once. Normally, if you have inflammation here, it swells there because they dilate there. That's part of the inflammatory response. But if you all dilate at once, there's not enough blood in there to keep the pressure up. Your pressure drops down and you can't make it. Septic shock, the same thing. If a bacterial infection that was local goes system-wide through the bloodstream, you get an inflammatory response everywhere at the same time. Your blood pressure drops, and sometimes it's not survivable. A friend of mine on the island that I came from had septic shock. He got pneumonia. He refused to go to the hospital soon enough. Hale, hearty guy. The pneumonia went septic. The bacteria went throughout his entire bloodstream. They put him on blood pressure razor medicines and everything they could do. His blood pressure simply wouldn't come back up and he died. Neurogenic shock, big drop in sympathetic, increase in parasympathetic. Either one will cause a drop in blood pressure, all the blood pressures relax, the resistance goes down, so now there's no resistance to blood flow. It all just hangs out in the periphery, and there's not enough venous return to maintain any cardiac output. The tissues start to die because they're not getting any blood, and you have tissue death, especially organ failure. Hypovolemic shock, same thing. Not enough blood. You try to increase it as best you can, but if it doesn't bring you back up to a survivable amount, if you're still bleeding, for instance, it drops, and tissues start dying. Septic shock. Bacterial infection secondary to other disease conditions. Pneumonia, huge GI tract infection, major other lung infections. It doesn't matter where it starts. If it gets out of the tissue and into the blood and proliferates and increases and you don't catch it soon enough, it'll cause a body-wide inflammatory vasodilation response and your blood pressure drops. Here we are. I've already mentioned this. A couple of different receptors from the different organisms, though, that cause the release of all of these cytokines that cause the inflammatory reaction that causes the drop. All of this stuff kind of a reminder of back in our infection and inflammatory lectures. And ultimately, multiple organ dysfunction syndrome, all it means is you haven't had enough blood in your organs for too long, they start to die. Kidneys are a main one. I mean, of course, if your brain dies, that's pretty bad. But if your kidneys fail, then you really can't control your blood volume. The heart's not working, the kidney starts to fail. The liver shuts down, and it is required to filter the blood. Now the blood becomes more and more toxic, and it's simply a spiral that takes you down and down and down. Sepsis usually. Although not enough blood. Too much bleed out, the same thing will happen. You'll have multiple organ failure just because you don't have enough blood. But here, you can follow the pathway. You need more oxygen than you have, and so that you have hypoxia, acidosis, damage to the cells. They start, the ATP pumps stop working, so sodium builds up inside, the cells swell up and start to explode, and those organs become irrevocably damaged and you die. Ischemic heart disease next time.